In this video, we'll discuss about acute renal failure. So first of all, the definition. The definition stands for like it is the sudden and usually reversible deterioration of renal function developing over over weeks and days with rapid rise in blood urea. The characteristic feature of acute renal failure is that there is a rapid rise in the urea and there is a decrease in the urine volume, and there is acid base fluid electrolyte balance disturbance. Now, coming on to the causes, what really causes the sudden and the reversible deterioration of the renal functions that develops over weeks and days with rapid rise in blood urea? First of all, to understand the causes, we divided them into three categories. First is pre-renal, then intrarenal, and then post-renal. Post-renal will obviously be an obstruction in the ureter. Okay, now coming on to the pre-renal. To remember pre-renal, we will remember the acronym CHASS. Okay, so first of all, C stands for cardiac failure, then pancreatitis. Okay, H stands for hemorrhage and intravascular hemolysis. A stands for anemia or anesthesia. S stands for severe burns, also stands for shock. Now, in the intravascular, to remember this, you can remember that there was a person named Vasu and he was immortal. So we say immortal in Hindi as Amar. So remember this acronym for intrarenal. Now I'll tell you what stands for what. Now, by Vasu, you can write vasculitis. Through A, you will write acute tubular necrosis. By M, you will write microangiopathic hemolytic states. Then again, we have A. By A, you will write acute tubulointerstitial nephritis. Then we have R. With R, you can write renovascular obstruction. Then we have one more R left, which stands for rapidly progressive glomerulonephritis. Okay, so these are the causes. Now coming on to the clinical features, we'll discuss the clinical features based on the etiology, and we'll discuss the diagnosis and treatment. So first of all, coming on to the pre-renal acute renal failure. So over here, what we see is in all these there is no example in which there is already a pre-existing renal disease. So we will first of all write there is no history of pre-existing renal disease. Okay, now as I mentioned earlier, in acute renal failure what we see is we see uremia, oliguria and anuria. So you will mention it over again here. So you will write oliguria and anuria. Then there is uremia, as I told before, and so there is rapid rise in urea and creatinine. Rapid rise in urea and creatinine. Now, urine osmolality is greater than 600 milliosmol per liter, and urinary sodium excretion is around less than 20 millimole per liter. Now, coming on to the treatment for pre-renal, the treatment is, first of all, you find the underlying cause and treat it. So, treat the underlying cause, treat the underlying cause. Then, you must also work on the volume replenishment, and then by this can be done by judicious use of inotropic agents. This is guided by central venous pressure as well as PCWP. Okay, now coming on to the intrarenal. In intrarenal, first of all, why is intrarenal actually occurring? So it is occurring due to, because there is already some of the injury is already done to the cells of kidney. So first of all, we'll understand it that it is occurring due to three factors. The first one being that there is an increased intrarenal vasoconstriction with decreased vasodilation. Then, due to this increased pressure, there is ischemia and there is tissue cell injury, which is further leading to cell apoptosis and death. Why is there tissue cell injury? Because of this, there is ischemia, due to which there is tissue cell injury. Then, in the third one, it is actually followed by recovery. Now, the you must remember that the tubules have the capacity to regenerate or to reform the disrupted tubules, so there will be a recovery phase. Okay, now coming on to the three phases, and first of all, the first phase being oliguric phase, the second one being diuretic phase, and the third one being the recovery phase. Okay, so first of all, the oliguric phase. In the oliguric phase, what we see is that there is a the volume of urine is around 300 ml. Here, the urine passed is 3 to 5 liter for 3 to 5 days. This remains for around 7 days to 10 days. In the diuretic phase, what we see is that the volume of urine is increased, whereas in this, we will observe that the urine, it contains the red cell casts, the WBCs. Okay, in diuretic phase, we will basically stick to a fluid and electrolyte regimen, because most of them this okay. Now what you'll see here is, you will see, this is a very important point to remember. In oliguric phase, you will see hyperkalemia occurring, whereas in diuretic, you will see that there is hypokalemia. Okay, over here you can also see pulmonary edema and metabolic acidosis. Here you can see hyponatremia and dehydration, because a lot of urine is being passed out. That is 3 to 5 liters per day. Okay, that also for 3 to 5 days. Now, in the recovery phase, what you see is the blood urea level, the creatinine, GFR, they all are normal. Okay, this usually stays for 7 to 20 days, and this is basically a mild form of renal dysfunction. So, the treatment, yeah. So, over here, you see that there is hyperkalemia. So, first of all, we'll treat hyperkalemia uh, by insulin, calcium gluconate. You must always mention that we have to find the underlying cause and treat it. Then there is hypertension as well. To control the hypertension, we might give antihypertensives. We will give a salt and water restricted diet. We will administer diuretics. Now, a very important point to remember: for renal protection, you can give dopamine in the dose of 2 to 4 microgram per kg per minute. Then you can also administer loop diuretics. Water and electrolyte balance has to be maintained. Now, to remember here, there's one more point. First of all, you can give water, obviously, but electrolytes are usually not given because already there is a lot of imbalance. Also, it is given in the other stages. So, there can also be hypercalcemia and hyperphosphatemia. So, for this, you will concentrate the on more on the diet, as well as you can give binding agents as in ALOH whole thrice, or you can give calcium replacements. Protein is a very important factor, so you must have at least 0 to 5 grams per kg in daily diet. Infection should be controlled. Also, for metabolic acidosis, we will give sodium bicarbonate in the dose of 50 to 100 milliequivalent every 6 hours. Okay, now this is it. Now for the treatment of diuretic, as I mentioned before, here you will give all the fluid and electrolyte. You can give glucose saline, okay, and fruit juices, 70 to 80 grams of protein. Now, as I told you before, the last resort of treatment in acute is always dialysis, whereas in chronic it is renal transplantation. So dialysis, the indications of dialysis, to remember the indications of dialysis, you can remember someone named as home fu. Okay, home fu. So in this is the acronym, and it stands for hyperkalemia. Whenever there is hyperkalemia, now when is hyperkalemia condition? When the potassium is more than 6 milliequivalent per liter. Then if there is oliguria with rapid rise in blood urea, if there is metabolic acidosis, if there is fluid overload which is not controlled by fluid restriction and diuretics, if there is uremic pericarditis. So this completes the acute renal failure. So to sum up again, first of all, it is the sudden and reversible dysfunction, kidney dysfunction, deterioration in the renal functions over weeks and days, with rapid rise in blood and urea. So there is a decrease in the urine volume and acid base electrolyte. Okay, now in pre-renal, to remember this, you will remember this. C stands for cardiac failure, H hemorrhage, then A for anesthesia, shock, and severe burns. Okay, this is the minimum you should remember. Now coming on to this intrarenal, Vasu, there's a person named Vasu who's immortal, so you call him Vasu Amar. So vasculitis, then we have acute tubular necrosis, microangiopathic hemolytic states, then we have acute tubulointerstitial nephritis, R for renovascular obstruction, and then another R for rapidly progressive glomerulonephritis. Now coming on to the clinical features in pre-renal, what we'll see is there is no history of the pre-existing renal disease, and there is oliguria, uremia, anuria. Then the osmolality, you must remember this. The treatment is basically we give the fluid replenishment based on CBP and PCWP. Now on intrarenal, you must remember it is occurring due to three factors. The first being that there is a lot of intrarenal vasoconstriction, and there is very less vasodilation, due to which less blood will be supplied. So there will be ischemia. Ischemia will lead to tissue cell injury. So it will further lead to cell death and apoptosis. But you must remember that the renal tubules have the ability to reform the deteriorated tubules, also to regenerate, so it can be followed by recovery. Now coming on to the phases, the first one is oliguric, then diuretic, then recovery. In oliguric, you will mention everything that you know about acute renal failure, but you must remember over here in oliguric you will see that there occurs hyperkalemia, but in diuretic there is a hypokalemia. Okay, there is a decrease in the potassium levels. When is potassium level considered to be increased? When it is more than 6 milliequivalent per milliliter. Then there is pulmonary edema, metabolic acidosis, hypertension. Accordingly, you treat it, and same as with this. Over here there will be hypertension and dehydration. Why? Because 3 to 5 liters of urine is being passed per day for 3 to 5 days. Okay, so to treat that, you give glucose saline and 70 to 80 grams of protein. Whereas in recovery phase, what we see is all the factors like blood urea, creatinine, and GFR, they become normal. So it usually takes around 7 to 20 days. Now, when will you resort to dialysis? When it is the severe form, when it is not in recovery state. So when it is in basically when there is these conditions are occurring. First of all is hyperkalemia, then is oliguric with rapid rise in blood urea, metabolic acidosis, then fluid overload which is not being controlled with fluid restriction and diuretics, and the last one being uremic pericarditis. In the next video we will discuss about chronic renal failure. Then we'll discuss about other questions.